Welcome to the October 2016 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 5 scientific articles published in the October issues of the journal, as well as a commentary by Dr. Nicholas J. Giori on the article entitled Meaningful Thresholds for the Volume Outcome Relationship in Total Knee Arthroplasty. Be sure to check out this month's Current Concepts Review article on developing a clinically representative model of periprosthetic joint infection by Dr. Alberto Carli and colleagues. The authors note that the poor treatment outcomes for periprosthetic joint infection reflect the limited understanding that currently exists with regard to the pathogenesis of this devastating clinical problem. They believe that a greater mechanistic understanding of the musculoskeletal and immune systems of small animals, such as mice and rats, will provide a more robust platform for modeling and examining the pathogenesis of periprosthetic joint infection. The authors break down the process of developing an animal model of periprosthetic joint infection through extensively reviewing pertinent topics, including animal physiology, principles of implant design, and characteristics of both bacterial activity and virulence. In this issue, JBJS.org presents a new image quiz, a 9-year-old girl with hip pain and fever. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 5 that are being presented in this podcast. This abstract is from the article entitled Radiographic Changes in the Cervical Spine Following Anterior Arthrodesis, a long-term analysis of 166 patients by Dr. Rajdi Rao and Associates. Investigation performed at the Department of Orthopedic Surgery, Medical College of Wisconsin, Milwaukee, Wisconsin. Adjacent segment degeneration frequently develops following anterior cervical discectomy and fusion. The objectives of the present study were to characterize the long-term evolution of degenerative radiographic changes at segments adjacent to anterior cervical fusion and to identify factors associated with the development of these changes, including the preoperative condition of the cervical spine and parameters related to arthrodeses. 166 patients who underwent anterior cervical discectomy and fusion for symptomatic cervical spondylosis or disc herniation were followed radiographically for a mean time of 12.7 years. Radiographic changes representing degeneration at adjacent levels, including disc height loss, osteophyte formation, end plate sclerosis, and facet arthrosis, along with changes in sagittal alignment of the fusion segment and cervical spine, were recorded preoperatively and at the time of the latest follow-up. Regression models were used to identify the parameters that affect these degenerative changes. More than 90% of patients had worsened anterior and posterior osteophytes at segments immediately adjacent to the fusion. Degenerative changes were significantly affected by the proximity of the level to the fusion and were inversely affected by the preoperative degenerative changes present at the segment. The time elapsed since the surgical procedure was a significant predictor of degenerative changes. However, the patient age, the number of levels fused, and the sagittal alignment of the fusion segment had no influence on the degenerative changes at adjacent segments. Conclusions. Multiple factors likely contribute to adjacent segment degeneration following cervical arthrodesis. Although mechanical parameters associated with arthrodesis, such as length and alignment of the fusion, did not appear to play a role, the preoperative degenerative condition of the spine and inclusion of C5, C6 in the arthrodesis influenced the incidence of adjacent segment degeneration. Next, you'll hear the second abstract of 5 that are being presented in this podcast. This abstract is from the article entitled Outcome of Revision Shoulder Arthroplasty After Resurfacing Hemiarthroplasty in Patients with Glenohumeral Osteoarthritis by Dr. Jeppe V. Rasmussen and Associates. Investigation performed at the Department of Orthopedic Surgery, Herlev University Hospital, Herlev, Denmark. Patients are often treated with a resurfacing hemiarthroplasty in the expectation that the bone-preserving design facilitates revision should the need for a revision arthroplasty arise. The aim of this study was to report the outcome of patients with glenohumeral osteoarthritis who underwent revision shoulder arthroplasty after resurfacing hemiarthroplasty. The authors reviewed all patients with osteoarthritis reported to the Danish Shoulder Arthroplasty Registry from 2006 to 2013. There were 1,210 primary resurfacing hemiarthroplasties, of which 107 cases required a revision surgical procedure, defined as the removal or exchange of the humeral component or the addition of a glenoid component. The Western Ontario Osteoarthritis of the Shoulder WOOS Index was used to evaluate outcome at 1 year. The median WOOS of revision arthroplasty after failed resurfacing hemiarthroplasty was 62 points. Of the 80 cases that had follow-up, 33 had an unacceptable outcome, defined as a WOOS of 50 points or less. Of the 107 cases that required a revision surgical procedure, 11 arthroplasties required a further revision surgical procedure. The resurfacing hemiarthroplasty was revised to a stemmed hemiarthroplasty, anatomic total shoulder arthroplasty, or reverse shoulder arthroplasty. In 7 cases, the revision arthroplasty design was unknown. The median WOOS of patients who underwent revision stemmed hemiarthroplasty was significantly inferior to that of patients who underwent primary stemmed hemiarthroplasty. The median WOOS of patients who underwent revision anatomic total shoulder arthroplasty was also significantly inferior to that of patients who underwent primary anatomic total shoulder arthroplasty. However, the median WOOS of patients who underwent revision reverse shoulder arthroplasty was not significantly different from that of patients who underwent primary reverse shoulder arthroplasty, used in the treatment of osteoarthritis. Conclusions. The outcome of revision shoulder arthroplasty after failed resurfacing hemiarthroplasty was variable and in many cases disappointing. It is important that resurfacing hemiarthroplasty is used for the correct indications and with adequate technique and skill. When resurfacing hemiarthroplasty is used in the treatment of osteoarthritis, revision cannot be counted upon as a fallback. Next, you'll hear the third abstract of 5 that are being presented in this podcast. This abstract is from the article entitled The Michigan Experience with Safety and Effectiveness of Tranexamic Acid Use in Hip and Knee Arthroplasty by Dr. Brian Hallstrom and Associates. Investigation performed at the Marquis Coordinating Center, University of Michigan, Ann Arbor, Michigan. The efficacy of tranexamic acid, TXA, in reducing blood loss and transfusion requirements in total hip and knee arthroplasty has been well established in small controlled clinical trials and meta-analyses. The purpose of the current study was to determine the risks and benefits of TXA use in routine orthopedic surgical practice on the basis of data from a large statewide arthroplasty registry. From April 18, 2013 to September 30, 2014, there were 23,236 primary total knee arthroplasty cases and 11,489 primary total hip arthroplasty cases completed and registered in the Michigan Arthroplasty Registry Collaborative Quality Initiative. The authors evaluated the association between TXA use and hemoglobin drop, transfusion, length of stay, venous thromboembolism, readmission, and cardiovascular events by fitting mixed effects generalized linear and mixed effects Cox models. We used inverse probability of treatment weighting to enhance causal inference. For total hip arthroplasty, TXA use was associated with a smaller drop in hemoglobin, decreased odds of blood transfusion, and decreased readmissions compared with no TXA use. There was no effect on venous thromboembolism, length of stay, or cardiovascular events. For total knee arthroplasty, TXA was associated with a smaller drop in hemoglobin and 1/4 the odds of blood transfusion. There was an association with decreased risk of venous thromboembolism within 90 days after surgery, slightly decreased length of stay, and no association with readmissions or cardiovascular events. Conclusions. In routine orthopedic surgery practice, TXA use was associated with decreased blood loss and transfusion risk for both total knee and total hip arthroplasty, without evidence of increased risk of complications. TXA use was also associated with reduced risk of readmission among total hip arthroplasty patients and reduced risk of venous thromboembolism among total knee arthroplasty patients, and did not have an adverse effect on cardiovascular complications in either group. Next, you'll hear the fourth abstract of 5 that are being presented in this podcast. This abstract is from the article entitled Meaningful Thresholds for the Volume Outcome Relationship in Total Knee Arthroplasty by Dr. Sean Wilson and Associates. Investigation performed at the Healthcare Research Institute, Hospital for Special Surgery, New York, New York. Increasing evidence supports the finding that patients undergoing a total knee arthroplasty with high-volume physicians and hospitals achieve better outcomes. Unfortunately, the existing definitions for high-volume surgeons and hospitals are highly variable and entirely arbitrary. The aim of this study was to identify a set of meaningful hospital and surgeon total knee arthroplasty volume thresholds. Using 289,976 patients undergoing primary total knee arthroplasty from an administrative database, the authors applied stratum-specific likelihood ratio (SSLR) analysis of a receiver operating characteristic ROC curve to generate sets of volume thresholds most predictive of adverse outcomes. The outcomes considered for surgeon volume included 90-day complication and 2-year revision. For hospital volume, the authors considered 90-day complications and 90-day mortality. SSLR analysis of the ROC curves for 90-day complication and 2-year revision rates by surgeon volume identified 4 volume categories: 0 to 12, 13 to 59, 60 to 145, and 146 or greater total knee arthroplasties per year. Complication rates decreased significantly in progressively higher volume categories. Revision rates followed a similar pattern, but did not decrease between surgeons performing 60 to 145 arthroplasties per year and those performing 146 or more arthroplasties per year. SSLR analysis of 90-day complication and 90-day mortality rates by hospital volume also identified 4 volume categories: 0 to 89, 90 to 235, 236 to 644, and 645 or more total knee arthroplasties per year. Complication rates decreased significantly in progressively higher volume categories, but the rates did not decrease between hospitals performing 236 to 644 arthroplasties per year and those performing 645 or more arthroplasties per year. Mortality rates for hospitals with 645 or more total knee arthroplasties per year were significantly lower than those below the threshold. Conclusions. This study supports the use of SSLR analysis of ROC curves for high-risk-based volume stratification in total knee arthroplasty volume outcomes research. SSLR analysis established meaningful volume definitions for low, medium, high, and very high volume total knee arthroplasty surgeons and hospitals. This should help patients, surgeons, hospitals, and policymakers to make decisions with regard to the optimal delivery of total knee arthroplasty. Next, you'll hear a commentary by Dr. Nicholas J. Giori on the article entitled Meaningful Thresholds for the Volume Outcome Relationship in Total Knee Arthroplasty.
This is Dr. Nicholas J. Giori providing commentary for the October 2016 JBJS podcast. I will be providing commentary on the article entitled Meaningful Thresholds for the Volume Outcome Relationship in Total Knee Arthroplasty. The title of my commentary is, Should Only the Highest Volume Surgeons and Centers Be Doing Primary Total Knee Arthroplasty? Every year, approximately 1 million new patients undergo a total knee arthroplasty in the United States. A great majority experience pain relief, improved function, and improved quality of life. But complications occur in a fraction of patients. A complication following total knee arthroplasty can be devastating and life-changing for the patient. Furthermore, complications are extremely costly to the healthcare system. Maintaining access to the surgical benefits while minimizing the number of complications is a paramount challenge. Various studies looking at post-surgical morbidity and mortality have found that busier is better. In their article, Wilson et al. Went beyond what had been done in prior studies by using a novel statistical approach to specify surgical volume thresholds that correlate with increments in outcomes. Thus, the thresholds are based on actual data from the administrative database that they studied rather than arbitrary values. As is noted in their excellent article, they answered the question of how much busier is better. This is an important advance over the prior literature on this subject. However, there are several important questions that arise as we move forward from this point. The first question pertains to the specific results of the article itself. Are the specific thresholds defined in this article generally applicable? This is an important question as it will be tempting for surgeons, administrators, and patients to focus on the exact thresholds reported. The only thing of which we can be certain is that the thresholds that are calculated and are reported in this work pertain specifically to the data that was studied. It is very possible that a similar study on another data set in another location with different surgeons over a different time interval would result in different cutoff values among low, medium, high, and very high volumes with regards to surgeons and hospitals, and that the increment in risk associated with these different cutoff values will change. Before these specific cutoff values are used to inform surgeon and hospital selection or, on a larger scale, healthcare policy, it will be important to validate the conclusions of this study on an entirely different data set. Indeed, as practices and procedures change over time, these cutoff values may all end up being moving targets. Even if such information could be validated and updated on a continuing basis, a larger and more meaningful question arises. How do we use these data? The logical conclusion of this article is that all total knee arthroplasties should be done in hospitals with greater than or equal to 645 cases per year by surgeons performing greater than or equal to 146 cases per year. Should this become policy among payers for total knee arthroplasty? Large integrated healthcare systems have moved in this direction, routing knee replacement cases to larger specialty centers and higher volume surgeons, and some large corporations have contracted directly with very high volume medical centers for their employees' joint replacement surgical procedures. However, this approach may not be broadly applicable to the United States healthcare system, at least as it is structured presently. Many parts of the United States do not have such large centers and high volume surgeons nearby. Because many patients do not have the means or the social support to travel extended distances to specialized centers for their surgical procedures, the general implementation of such a policy would have the effect of restricting access to care. Should patients only seek out surgeons in hospitals with volumes that rise above the highest thresholds? The authors suggest that surgeons in the lowest tier of volume consider removing total knee arthroplasty from their practice offerings to focus on other aspects of their practice, and I believe that this is a reasonable consideration. However, although multiple studies, including the present one, have found a statistical relationship between volume and reduced complication rates, not all of the highest volume surgeons in hospitals are exceptional and have better outcomes than all surgeons in hospitals that fall below the highest tiers. We all know that there is more to being an excellent orthopedic surgeon or an excellent hospital than simply volume. Volume is one of a number of different considerations that should be taken into account in choosing a surgeon or hospital. Finally, is there something that can be done to alter the findings of this study and make quality of care more uniform across surgeons and centers of varying volume? It has been shown that standardization of care can improve quality. Surgeons and hospitals can learn best practices from the best and highest volume surgeons and hospitals and adopt these practices in lower volume settings to improve care and outcomes.
Next, you'll hear the fifth abstract of 5 that are being presented in this podcast. This abstract is from the article entitled Asymptomatic Pseudotumors in Patients with Taper Corrosion of a Dual Taper Modular Femoral Stem, Mars MRI, and Metal Ion Study by Dr. Young Min Kwan and Associates. Investigation performed at the Center for Metal-on-Metal Hip Replacement Evaluation and Treatment, Massachusetts General Hospital, Harvard Medical School, Boston, Massachusetts. Modularity in total hip arthroplasty facilitates intraoperative restoration of patient anatomy. Although dual taper modular total hip arthroplasty offers potential advantages for optimizing the hip center of rotation, it has been associated with modular taper corrosion. This corrosion has led to adverse local tissue reactions, pseudotumors, at the neck stem junction, and elevated metal ion levels. However, the occurrence of taper corrosion-related pseudotumors in patients who remain asymptomatic following total hip arthroplasty with a dual taper modular femoral stem remains largely unknown. The aims of this study were 1. To determine the prevalence of asymptomatic pseudotumors by utilizing metal artifact reduction sequence magnetic resonance imaging, MARS MRI, and 2. Compare serum metal ion levels between symptomatic and asymptomatic patients with a dual taper modular stem total hip replacement. The authors performed a retrospective cross-sectional study of 97 consecutive patients who'd been treated with a dual taper modular femoral stem total hip arthroplasty. 83 patients were stratified into symptomatic and asymptomatic groups and evaluated with MARS MRI, measurement of serum metal ion levels, and the University of California at Los Angeles, UCLA, functional hip score. The prevalence of pseudotumors as determined with MARS MRI was 15% in the asymptomatic patients and 36% in the overall cohort. The median serum cobalt level and cobalt-chromium ratio were significantly higher in patients with a pseudotumor than in those without a pseudotumor. However, there was no significant difference in the serum cobalt level or cobalt-chromium ratio between symptomatic patients with a pseudotumor and asymptomatic patients with a pseudotumor. The UCLA scores of asymptomatic patients with a pseudotumor were similar to those of patients without a pseudotumor. Conclusions. The prevalence of asymptomatic taper corrosion-related pseudotumors on Mars MRI in this study demonstrated that the absence of symptoms does not exclude the presence of adverse local tissue reactions. Elevated cobalt levels and cobalt-chromium ratios were associated with the presence of pseudotumors in asymptomatic and symptomatic patients. Cross-sectional imaging, such as Mars MRI, is indicated for patients with elevated metal ion levels. A longitudinal study is required to determine whether asymptomatic patients with taper corrosion-related pseudotumors will develop symptoms with time. Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.